Thanks, Will, and thanks to all the presenters. What a really fantastic set of talks. I'm sort of very excited actually about the discussion and to hear more about what other folks are thinking, not just my thoughts on these papers. But I thought they were a really great set of talks. So I'm going to be fairly brief. I just wanted to give a little bit more context about sort of the results. So I've looked up some interesting comparisons that we can think about. But just to sort of set the stage, I just for my own sake, I kind of wanted to look up sort of what do we know about health in India and how it's been changing and thinking about health and mortality. So this is just pulling data from this is UNWPP data from our plot taken from our world in data. And you can kind of, I just plotted India along with some of its neighbors, and you can see the sort of dramatic increase in life expectancy that we've seen sort of across the world. India is not an exception. You can see how it does compared to countries that are its sort of immediate neighbors in South Asia. It's somewhere in the middle. Sri Lanka, we think of having a really good healthcare system in some ways, and so Sri Lanka is maybe perhaps a little bit of an outlier for South Asia, but you can see that India has had these dramatic increases. But what I think these papers have showed is that despite this general trend of better health and longevity in India, we have pretty important health disparities that we kind of need to consider. And then this was just to, it's just looking at life expectancy conditional having survived to a certain age. You can see most of the gains have come from reducing infant and child mortality. And even now, there's still a big gap. So infant and child mortality is still probably where most efforts are being focused in India, but there is a lot to be done to make further reductions in sort of adult mortality to improve the life expectancy. And you can look at sort of what the causes of death in India is, and so this is data from the global burden of disease. So you can imagine pretty large confidence intervals around all of these estimates. So take it with a grain of salt. But you can kind of see cardiovascular diseases, respiratory diseases, cancer coming up. And the reason I wanted to show this is because it's related to sort of, what does it mean if we see differences for air pollution exposure? What does it mean if we see differences in obesity and the causes of death are kind of, might show that we kind of need to address some of these disparities to get at, particular things like respiratory diseases, cardiovascular diseases. So the first paper looked at maternal mortality rates in India, and I thought this was a really, really fascinating paper. And Sangita and her co-authors really thought very carefully about how do you adjust for using these two measures, the numerator and denominator coming from two different sort of samples and two different populations. And so they've thought pretty carefully about how to combine this. And I think it kind of highlights the challenges of working in sort of data poor settings where you don't have vital registration systems that you can kind of pull these kinds of data from. So I think this is a great example of using survey-based methods to get at this estimate, and they find this pretty, as Sangita talked about in her talk, this pretty significant gradient if you look by caste. And just to give a little bit of context for what this gap means, Sangita actually mentioned this in her talk. If you look at the U.S. gap, the magnitudes are about the relative differences are about the same. The magnitudes are very different in India. So in India, you have the order of magnitude in the high caste Hindu, it's 147 deaths per 100,000 live births. In the U.S., it's much lower overall, but you can see that this gap between non-Hispanic Blacks and whites, for example, is roughly sort of comparable. And then I also kind of looked up some data from nearby countries. So this is data from Bangladesh, and you can see in probably the socioeconomic gradient and the education gradient is probably what's closest to what we're seeing in India. And the reason I'm showing this is I just kind of wanted, Sangita actually addressed this really well in her talk about what's behind this caste difference that we see. And it, in her work, it doesn't appear to be driven entirely by income or those differences, but it's interesting to sort of think about what could be driving it. So some of my comments and thoughts, one sort of kind of mechanical or technical thing I thought a little bit about is, the authors have done a pretty careful job of explaining that it's not the age pattern of fertility that's explaining it. But sort of as a demographer, I always kind of think about the age composition effect, and I don't think this is probably going to be the thing that explains your results by any means, but probably worth it to consider because we know the maternal mortality ratio increases so dramatically by age. Are there compositional effects by age? For example, are there just more Muslim women who are 40 and older? Even if the fertility schedules look the same, could explain the difference. So at least worth having a sort of sensitivity to kind of show that it's not the age compositions of these groups. The other thing I thought about is, I'm assuming there's probably, spatial variation. You talk about the rural-urban differences, but I'm wondering if you could look at within state variations. And I think Will had a comment actually in the chat, perhaps that's along the lines of I think Will suggest perhaps you could do a fixed effects regression, but I was thinking if you could look at the within state variation to deal with some of the issues of how healthcare access or other things might vary. The other thing I thought, and this is probably not part of this project, but just more generally thinking about what are the causes of death across these groups. So I know in Bangladesh there's been some work to do verbal autopsy data specifically for maternal mortality, and there are differences in the cause of death if you look by socioeconomic status in Bangladesh. So I just sort of a more broader question of if we see differences in what the cause of death is for these groups, perhaps there's ways to intervene or public health efforts that could try to address some of it. But I think, again, in these settings, it's hard to get data on cause of death, especially, related to, I think, things like maternal mortality. But I'd be curious to hear your thoughts on this. And then the other thing I was sort of curious and would love to hear your thoughts on is if you've thought about looking at trends over time. Are things improving? Are things getting worse and more unequal? It's sort of thinking ahead, what might we expect, and sort of if you could use the DHS data to think about those trends over time. So those were my comments for that paper. And then moving on to the paper by Zhiyong, then again, really wonderful example of how to use survey-based data to try and get at some of these complex questions. And so in this paper, Zhiyong then was looking at different measures of social capital. So I thought it was really interesting how you, and again, in your talk, you did this as well, but also in the paper, how you laid out these three, what you categorize as three different types of social capital, and theoretically how these could have sort of different effects on health. And I really like the way that you think about how your caste status gives you, not just this overall mortality effect, but how it has a different, your access to different types of capital are different based on your caste. And so I thought this was a sort of a very nice way to link these two things. My sort of broad comments again, I thought about what role does age structure play here. Again, probably not the thing that's explaining, but sort of always good for anything to relate it to mortality, say, well, it's not the age composition of these groups that's driving it. The other thing, and I think this is true probably for all 4 talks, and we can talk about this in the discussion, maybe folks in the audience would have thoughts, but just the challenges of calculating mortality rates from these kinds of data, and you use the 2 waves of the data set, what is sort of, thinking about whose deaths are you capturing, what's the person years exposure and things that there's sort of complicated questions around that perhaps we can discuss more. And then sort of more broadly, one of the things I'm curious about is just how should we think about different measures of social capital and how they might theoretically be linked to mortality, right? So you lay out these three different types and what they mean for power and financial access and who you're connected to. But then how do we link these to mortality? What is it about these forms of social capital that matter, right? Is it financial support? Is it emotional support? Is it trust in authority? Is it something else? And this is a paper by Ichiro Kawachi from a really long time ago, one of his earlier papers that I often have my students read, but it lays out this interesting dynamic between income, social capital, and health, and raises all sorts of interesting questions about what is causing what, right? So income gives you differential access to social capital, but also has an effect of health, independent of social capital, perhaps, but then health might also have an effect on income and social capital. And so, this is one example where they looked at, income inequality and how sort of whether people felt like they were safe in their community, they felt like no one would take advantage of them. And they show that that's related to mortality, but it's also related to income inequality. So one thing that I would be sort of curious to hear about it, you say you control for income in your model, but sort of there's interesting dynamics going on because there's caste differences in income and caste differences in different types of social capital and mortality. So how are you thinking about these things and sort of, especially in a causal framework, what's driving what? So those were broadly my comments. And again, I thought it was a really sort of wonderful piece of work. Moving on to sort of the last paper that we just saw. This is by Bittu Mandal, and he was describing his work looking at obesity, so not mortality, but now looking at some of the risk factors for mortality, and specifically looking at this really interesting question of comparing migrants from rural areas to urban non-migrants. So in some ways, this is kind of this broader context of sort of social assimilation, but in the context of health, do rural migrants end up looking adopting the behaviors and looking more like urban non-migrants the longer they spent in the urban area. So again, a really interesting question in the context of India, because the rural to urban migration rates have been sort of staggering in India. So really sort of an important question to address. And if you look at obesity rates in India, that it has been growing steadily. Again, I just plotted this or just grabbed this from the Our World in Data. You can see where India lies in relation to its neighbors. Again, sort of maybe sort of the bottom half of but comparable to their neighbors. It's interesting if you put the U.S. on this plot, which I just did just to understand the magnitude. It's completely different scale, which is related to one of my comments. So it's kind of why I wanted to sort of show the scale. And then just what do we know about BMI and mortality? Well, I looked this up because I kind of wanted to know what are some of the thresholds we know. This is from a New England Journal paper from 2006, but essentially what they find, they're looking at cohorts and mortality of these mortality over the age of 50, and you can kind of see the highest risk is if you're at BMIs of roughly 35 and over. So in the U.S. context, that's sort of what seems to matter. And sort of related to this, one of the things that I thought about is sort of what evidence do we have from India on this link between BMI or waist circumference and health, and sort of what is the threshold that we should care about, because a lot of this obesity research is from the more high income countries and particularly the US and so on. And so what do we know about sort of in South Asia about BMI and the link with health, and what thresholds matter for mortality or poor health outcomes? A technical point I had is sort of, and maybe this is no longer true, it was perhaps in the paper you shared, but you've been doing your models on stratified samples, and I was wondering what your results might look like if you did a pooled model, and does it make a difference? Another thought I had is sort of, does age at migration matter? So does it matter if you migrated when you were, a child, as a 5-year-old? Does it matter if you migrated later in life? Because there's probably, different health effects depending on, the age at which your BMI at a specific age and what that means for your health outcomes, and thinking about, perhaps there's selection effects on who migrates at age 5 and who migrates at age 45, but interesting to think about whether age at migration matters. And then you find this pretty substantial gender difference, which seems much larger than almost any other difference you find. So I was just sort of curious about what might explain some of these gender differences, and sort of, what's going on, and how do we think about it. So that was kind of, it really sort of got me kind of interested and curious. So again, a really wonderful paper, and I think really important to study in the context of India, both because we are seeing this increase in obesity, and we are seeing a lot of rural to urban migration that's predicted to continue for the next, however long. And so it's important to think about how the health of these migrants are changing, and what that might mean for future